Hello and a warm welcome to this module on breastfeeding of low birth weight and sick newborn and BFHI. I am Dr. Shashidhar. I currently work at St. John's Medical College, Bangalore. In this module, our objectives are going to be to appreciate the physiological vulnerabilities and the need for breastfeeding even small and sick newborns, to formulate a typical feeding regimen in these low birth weight newborns, and also to understand the core principles of baby friendly hospital initiative and its application to neonatal wards. So let's get started. In India, about 1/3 of all babies born in this country are low birth weight, and they amount to about 8 million births a year. They are very vulnerable because they are at 11 to 13 times higher risk of dying. And low birth weight can be either because they are born early, that is preterm, or they have not grown according to their growth potential, which is fetal growth restriction. These low birth weight newborns have a lot of feeding difficulties. One, because of prematurity itself. Two, because of fetal growth restriction, there is an altered gut perfusion which due to increased resistance in the umbilical arteries. Three, there is non-availability of mother's own milk in adequate volume, especially in the first few days after birth. However, these newborns have to record the highest growth rates if they are inside the mother's womb. That is at 15 grams per kg per day to 20 grams per kg per day. A normal fetus between 24 to 40 weeks increases its birth weight by about 6 times, body length by about 20 centimeters, and the brain growth by about 4-fold because of higher nutrition or nutrient accretion. If the baby is born early or preterm, these newborns miss out on all these increases in nutrient accretion, leading to missed opportunity of growth. There are various challenges in feeding a preterm or low birth weight. On one hand, as we saw, they have higher nutrient requirements compared to term infants due to their depleted growth stores, their higher growth rates, and also physiological immaturity. On the other hand, these low birth weight and sick newborns need additional intake to replenish their stores, to catch up rapidly with their peers, and to compensate for immature gastrointestinal function with an underlying medical instability. So we have these dual challenges when we have to formulate a feeding plan for this preterm low birth weight or sick newborns. Our strategy or choice of nutrition is always enteral if it is possible. So use the gut if you are able to do so. But very few newborns, especially if they are below 30 weeks gestation or weighing less than 1.2 kilograms, may not be able to feed enterally, and they may need total parenteral nutrition during this period of sickness. Now, what to feed these babies? The first choice is unequivocally mother's own milk, because the benefits of mother's own milk have been studied a lot, and it has been proved that mother's own milk, it has no alternative even for this low birth weight and small newborns. If it is not available for any reason, the second choice would be to feed donor human milk from other mothers, which is pasteurized. Third choice would be to feed a standardized preterm formula, and that is the last option. When we compare the constituents of preterm and term milk, we see that there is a higher protein content in preterm milk. There is a higher iron content, zinc content, sodium, as well as vitamin D. All these nutrients are much essential for a preterm babies to grow. So nature makes the preterm milk much more abundant in these nutrients to take care of the baby who are born preterm. However, we have to bear in mind that this protein content of preterm milk decreases gradually after birth and reaches the term concentration by 4 to 6 weeks, and where it resembles the term milk. There are a lot of benefits of feeding preterm milk to preterm babies. That is, it reduces mortality, it reduces necrotizing enterocolitis, it reduces anemia of prematurity, it improves neurodevelopmental outcomes, it reduces retinopathy of prematurity and causes less sepsis compared to formula feeds. So always prefer mother's own preterm milk as the first choice. However, the preterm baby's needs are so high that the preterm milk may not completely compensate for the preterm baby's nutritional requirements. In this graph, you see that the sodium, the calcium, phosphorus, iron, zinc, and vitamin A, though they are very high in preterm milk, they are unable to meet the requirements of a growing preterm baby. In these cases, we may need to supplement calcium, phosphorus, iron, multivitamins, including zinc for the preterm newborns when they are fed on mother's own milk. Secondly, sometimes, as we saw, there is a macronutrient deficiency as well. That is, the protein content reduces in the preterm milk, and the preterm babies who are not able to gain adequate weight, even on mother's milk completely, they should be given fortified mother's own milk. There are human milk fortifiers which are available, and they will be added to the preterm milk and fed to the baby if the babies are not meeting their requirements of growth. This is to prevent extrauterine growth restriction, where the babies tend not to gain weight for a long time. And if you don't address this issue, it can lead to poor neurocognitive outcomes. So we need to supplement preterm human milk whenever necessary. When to initiate feeding for the small and sick newborn babies? If the babies are weighing less than 1.2 kg, still you can start some amount of enteral feeding, about 10 to 24 ml per kg, preferably expressed mother's milk, that is colostrum, starting from first day of life. Rest of the nutritional requirement can be met by intravenous fluids and TP. If the baby is more than 1.2 kg at birth, they should be started on 60 to 80 ml per kg per day on first day of life, preferably again expressed mother's milk. Our aim in a small preterm baby is to reach full enteral nutrition, that is 150 to 180 ml per kg per day, by about 2 weeks if the baby is weighing less than 1 kilograms at birth, or by 1 week if the baby is weighing 1 to 1.5 kilograms at birth. I mentioned that you can give small amount of enteral nutrition for a baby who is on IV fluids and parenteral nutrition. This is known as minimal enteral nutrition. This has a lot of benefits even for a very small baby. It improves gut maturity, it improves gut level of hormones, it causes less feed intolerance, improves the weight gain, improves calcium and phosphorus retention, causes less or fewer days in TPN. It decreases the time to reach full feeds by about 2.5 days, and it reduces the overall hospital stay by about 11 days. So try to initiate as early as possible mother's own milk for even small babies. When this baby is born, this baby may not be mature enough to take direct breastfeeding from the mother. If the baby is extremely preterm, that is less than 28 weeks of gestation, baby will not have good strong sucking effort, and it will not have a very good gut motility. In these babies, you will need to give extra additional parenteral nutrition along with that, which is minimal enteral nutrition by orogastric tube feed. Between 28 and 31 weeks, baby starts to develop few sucking bursts, but there is no coordination between suck, swallow, and breathing. This group of babies need to be continued on orogastric feeding and also need to be given non-nutritive sucking. Between 32 and 34 weeks, this baby matures its sucking reflex, and also there is a coordination which develops between suck and swallow. In this group of babies, you can start the babies on pallida feeding or oral feeding. Also, you can continue non-nutritive sucking. If the baby crosses 34 weeks, then the baby's suck, swallow, and breathing coordination is mature, and these babies can be put on mother's breast directly to feed the mother's milk directly from the mother. So, initially, the route of feeding may be orogastric for babies who are less than 32 weeks of gestation. And when we assess the feeding readiness and oral readiness, if they are accepting well, we can transition to pallida feeding. If the sucks are effective and the baby crosses 34 weeks of postnatal age, postmenstrual age, then we can transition the baby to breastfeeding directly. If the very low birth weight babies are on intragastric tube feeding, they can be fed every 2 hourly, and if the baby weighs more than 1.5 kilograms, they can be even fed 3 hourly. When we start feeding these babies at 60 to 80 ml per kg on day 1 of life, if they are more than 1.2 kg, we will increase the volume as per the day of life and as per the feeding tolerance. If the feed and this volume increase can be up to 30 to 35 ml per kg per day, with careful monitoring for signs of feeding intolerance like vomiting, like abdomen distension, etc. If the feeding is by an alternative oral feeding method or intragastric tube, we can reach safely up to 180 to 200 ml per kg per day by about 1 to 2 weeks of life, which is known as full enteral nutrition. Now, what is this non-nutritive sucking? Non-nutritive sucking is a method where you stimulate the baby's sucking by either giving the baby an empty breast to suck. When you make the mother express and empty the breast, you make the newborn, who is very small, learn how to feed on the empty breast, or by a gloved washed finger inside the little finger inside the baby's palate to stimulate the hard palate. And this can be continued for about 5 to 6 minutes every time. What are the advantages of non-nutritive sucking? It improves the feeding behavior by improving the sucking. It improves the digestion by stimulating some enzymes in the saliva. It increases chance of early transition from gastric feeding to oral feeding by about 5 days. And it reduces the overall hospital stay by about 5 days. And also increases baby's physiological instability and reduces the pain for any procedures that you may be doing. You may you may follow this feeding protocol for a baby who is in the neonatal NICU, but you need to see the end result of good nutrition, that is baby's growth. Baby's growth needs to be monitored every day and needs to be plotted on a growth chart every week. We expect the baby's weight to increase as compared to the fetus, that is 15 to 20 gram per kg per day every day up to term. Length by about 1 centimeter every week, and head circumference should increase by about 0.7 to 1 centimeter every week. Bear in mind that there is an initial physiological weight loss of about 7 to 10%, and the baby regains birth weight by about 14 weeks. So this has to be incorporated into your calculation of weight gain. Later, the expected weight should be as per the baby's birth set time. So here you see a Fenton's chart which has been used. This is a girl baby, so we have used a girl Fenton's chart. This baby was born at 26 weeks, and this baby is continued to be on monitoring for about 30 weeks. And you see this baby has an initial postnatal weight loss, but it has regained birth weight, and the baby is now growing well. Coming to the second part of this module, that is neo-BFHI. BFHI stands for Baby Friendly Hospital Initiative. This was launched by WHO and UNICEF as a worldwide program to protect, promote breastfeeding in compliance with International Code of Marketing of Breast Milk Substitutes Act. This means there are some guidelines, there are some 10 steps for successful breastfeeding which is given to each hospital which provides maternity services, and this has resulted in a lot of improved outcomes, especially related to breastfeeding. But this was not implemented very well in newborn wards or NICUs. So in 2009, group of health professionals from different countries got together, formed a working group, and they formed some guidelines to implement this breast baby friendly hospital initiative to neonatal wards. Why do we need to implement this strategy? Because the NICU and neonatal wards have a unique set of challenges of their own. One, mother's access is limited to their infants because the infant and mother may be separated, mother may be far away for her own health reasons. We always feel that the baby is very fragile because of medical complications interferes with breastfeeding. These small preterm or sick babies have poor oromotor skills, poor suck swallow breathing coordination, as we discussed earlier. The physical environment of the NICU is not very conducive to breastfeeding. It causes high stress levels, it can be noisy and well lit, and for a new mother, it can be intimidating and stressful. When the mother sees her baby, she always sees a lot of equipment, lot of tubes, and lot of wires, which can be again stressful for her. Sometimes she may be inappropriately advised that her high risk conditions like increased blood pressure or increased blood sugar can interfere with adequate volumes of their own milk, which may not be true all the time. And there may be an inadequate knowledge for the staff and healthcare professionals, which increases resistance to change, and also because of high staff loads, we may not be able to sufficiently help her in breastfeeding. There may be some financial barriers to afford breast pumps or rent them, or cost of supplies of breast pump. So these are the unique challenges in newborn and NICU wards. So this new BFHI gives clinical guidance to all the hospitals which have neonatal wards, and it tries to adapt the baby-friendly hospital initiative to small and sick newborn infants in maternity wards or newborn wards. So it aids the staff, hospital systems to take care of breastfeeding, to promote, support, and protect breastfeeding in these situations. So it has 3 guiding principles and has adapted 10 steps of the BFHI to small and sick preterm newborn babies. And there is also a scoring system, and this Neo BFHI has also helped in improving breastfeeding rates in newborn wards. So these are the 10 steps, and these are the 3 guiding principles. The three guiding principles are: the staff's attitude to the mother should be individualized and to her situation. The medical condition, that psychological condition that she may be in, our attitude must focus on that. Second guiding principle, we must provide family-centered care, and this environment of the NICU should be conducive for family-centered or family participatory care, where the mother can look after her baby in a more meaningful way. And this healthcare system should ensure continuity of care, that is from before birth to birth and postnatal and post-discharge wards. The 10 steps I will not list out, you can see them, and most of the 10 steps are similar to the 10 steps of baby-friendly hospital initiative. So what can we do to overcome these challenges of small sick newborn baby unable to get mother's milk. Firstly, we must promote early skin to skin contact right after birth whenever possible. And this has to be continued as immediate KMC and also as prolonged KMC of more than 8 hours. This has a tremendous impact on low birth weight and preterm newborn mother's milk output, her confidence, and the baby's ability to feed also. The safety and stability of the mother are the prime criteria. Continuous and frequent skin to skin wherever possible. We should try to get the baby and the mother together as much as possible whenever we can. And with adequate monitoring and safe transfer of the mother if she is not in the hospital to the hospital that the baby is in. Secondly, we should establish methods to keep her and promote mother's milk supply. That is, we should instruct the mother on hygienic hand expression, even prenatally, and breast pump use as early as possible if it is available. We should instruct all the mothers on breast massage and breast pumping at least every 2 to 3 hours, at least 8 times a day, including nights. This collection should be safe, should be labeled, and should be stored, and should be given to her baby as soon as possible. So the breast pumping, her supply should be maintained, and she has to learn how to pump as soon as possible. For the babies, we need to give oral colostrum care which prevents infections in the baby, and also we should have preferably breast milk banks where we are storing and handling donor human milk. We may need to use some supplements like I mentioned earlier, but there has to be a policy of nipple shields and pacifiers when they should or should not be used. The transition from oral feeding to from gastric tube feeding to pallida feeding should be cue based. That means you should identify the baby's cues and then give the feeds to the baby and not just based on time. And there has to be protocols to say when to use fortifiers, when to use donor human milk, and when to use other supplements apart from mother's milk. The mother and baby should not be separated unless it is medically necessary. There should be a separate space for the mother to rest, which is preferably close to the preterm small sick newborn babies. And our visitation policies need to be encouraging the mother to visit frequently and whenever possible. And there should be a small breastfeeding group for her to express in privacy and to store her express mother's milk and refrigerate if needed. So key messages from these modules are that mother's own milk is the best choice even for small and sick preterm newborns. These preterm newborns have higher requirement of nutrients and they may need to be supplemented. There are significant challenges to breastfeeding in intensive care in neonatal wards, but they can be overcome by neo-BFHI strategies. Thank you and all the best.